Thank you for joining today's PCPCC webinar, Lifestyle Matters, Key Strategies to Improve Health for Those with Chronic Conditions. I'm Ann Greiner, President and CEO of the Patient-Centered Primary Care Collaborative, and I want to welcome today two leading experts who are going to convey strategies beyond conventional medicine to help people with chronic conditions heal by focusing on their lifestyle and health behaviors. First, let me start with some Patient-Centered Primary Care Collaborative housekeeping matters. If you are not an executive member of the PCPCC, I want to take this opportunity to encourage you to consider becoming a member. You can reach out to Jennifer Renton, and her email is right there on the screen to learn more about what membership entails and the value of membership. We bring together over 60 organizations that are committed to empowered, team-based primary care as the foundation of a high-value delivery system. And we work on policy and advocacy to advance this notion of primary care, research, lifting up exemplar models, as you will hear from our experts today, and also providing tools to practices to help them transform. I also want to call to your attention our conference, which is November 4 and 5 in D.C., and we've got a number of fabulous speakers at that conference, including Eric Topol from Scripps Research, who has been writing a lot about technology and its effect on primary care clinicians and patients, most recently a book about AI, and he has great hopes that AI can free up clinicians to spend more time with their patients. Also, Asaf Batan from Ariandi Labs, and Asaf has been doing a lot of work in primary care transformation, both domestically and internationally. Let me now introduce our panelists. We've got Katie Adamson. She's Vice President, Health Partnerships and Policy at the YMCA. And there are over 27 YMCAs across the country. So Katie has got a big job. She's very busy. She's providing guidance and consultation on healthy living policy. I love that concept of healthy living policy, partnership and program strategies at both the national and at the state level for all those local Ys. She helps advance healthy living legislation and advocacy strategies at the state and federal level, including drafting and implementation of legislative initiatives, policies. She assists with congressional, corporate, and health partnerships. Katie has over 27 years of experience in health policy, partnership development, and strategic planning in the nonprofit, private, and government sectors. After Katie provides some remarks, we'll hear from Dr. Wayne Jonas, who's a widely published investigator, practicing family physician, and professor of medicine at Georgetown University. He's also at the Uniformed Services University of Health Services. He's a retired lieutenant colonel in the medical corps of the U.S. Army, and he was director of the Office of Alternative Medicine at the National Institute of Health from 1995 to 1999. He also led the World Health Organization's Collaborative Center for Traditional Medicine. Prior to that, he was Director of Medical Research at Walter Reed. He now advises national and international organizations on ways to implement evidence-based healing practices. He draws on 40 years of research in patient care to explain how 80% of healing occurs organically and how to activate the healing process. And he has a book that I would highly recommend, and I'm currently reading, How Healing Works. After Katie and Jonas's presentation, we'll have time to hear from all of you. We've set aside about 10 minutes for Q&A. Please write in your questions into the chat box. Some of you have also sent in questions in advance. Let me turn the baton over to Katie.
Okay, thank you. So hello, I was asked to share with you a bit about what the Y has to do with helping people reach their full health potential, and also what our community integrated health model looks like. Oftentimes people know the Y from how they've experienced the organization. Their kids attend childcare, after school, or resident camp, or maybe their mom was in an older adult fitness program. Their brother might have been a camp counselor or coach. And if they don't know us, their default is that we're a gym or a pool. Well, I hope when I'm done, you'll understand that we're more than a gym. So what's the Y got to do with chronic disease prevention and health promotion? 15 years ago, we were looking at childhood obesity rates and chronic disease rates in the country and realizing that if we weren't a bigger part of the solution, we were part of the problem. Our physical footprint really demanded that we do more to improve the community's health. 80% of U.S. households are within 5 miles of a Y. We reached 22 million people through our 2,700 YMCAs that serve 10,000 communities. So how might we use our collective power to shift the needle on the epidemic trends we're seeing in chronic disease? To truly address the critical social issues affecting our communities, including chronic disease, the needs of our aging population, and health inequities, the Y recognized that we needed to have strategies on multiple levels working simultaneously to elevate well-being, prevention, and health maintenance. Many of you will have seen some version of this equation presented to us by the National Academy of Medicine or the county health rankings, namely, what influences health is often a factor of the community setting more than the clinical setting. Our strategies to date at the Y have addressed to some degree all of these factors impacting health outcomes. As this image depicts, the biggest contributor to health outcomes reside in the community, whether it's the physical environment where people live, work, learn, or play, their health behaviors, including diet, exercise, tobacco, etc., socioeconomic factors like education, job status, family support, community safety, and healthcare access and quality. The Y has worked over the past 15 years to address what role it might play in leveraging the value of community to improve health outcomes. This has led us to our current model of community integrated health. So I will share that model and work with you and what we've done in the community and state and with national partners that work on the aims to influence all these factors for health in the community. So this is our somewhat complicated looking model of community integrated health. We have learned that to address the high rates of chronic disease, the needs of our aging population, and health disparities, our approach again has to be multifaceted. We have worked for over a decade to advance policies and environments to change and make those communities healthier. We have been advancing evidence-based programs that address health disparities, and now we want to also partner with the healthcare system to shift the focus toward prevention and health maintenance. We call this body of work we've done to date and continue to do and have pilots underway to continue to test our community integrated health model. We have received substantial support and commitment from the Robert Wood Johnson Foundation to do this work. So let me share a bit with you about the different components. The first one, our Healthier Communities Initiative. Over a 12-year period, the Y was able to partner with CDC, Robert Wood Johnson Foundation, and thousands of partners on the ground in communities to create opportunities at the community and state level for healthy eating and physical activity aimed at where people live, work, learn, and play. This was done through several foundation and federal initiatives, and the combined impact of this work was powerful, and it was buttressed by several other national and foundation initiatives occurring across the country at the same time, including former First Lady Michelle Obama's Let's Move initiative. Our multi-sector stakeholder efforts in 247 communities resulted in 39,000 community-level policy systems and environmental change strategies that impacted up to 73 million lives. And our work in 20 states to advance 2,800 plus state-level strategies impacted up to 152 million lives. Efforts included improving food and beverage options in communities through access to farmers markets, healthy corner stores, and vending options, and improved school meals, as well as increasing opportunities for physical activity through safe routes to school programs, physical activity and recess in school and after school, and by limiting screen time. While much of the dollars for this type of work has sadly diminished, we continue to advance state-level strategies with CDC and state health and transportation departments to make communities more bikeable and walkable. Now I want to shift to our evidence-based health interventions. a body of work that has emerged over the last 12 years with federal partners like CDC and the Centers for Medicaid and Medicare Services, together with physicians at the AMA and the American Academy of Pediatrics, and patient advocacy groups like the American Heart Association, the American Diabetes Association, the LiveStrong Foundation, and the Arthritis Foundation. The Y has approached the rollout of our evidence-based health interventions through an extensive process. We first work with programs that have randomized controlled trials, and then we conduct applied translational research to ensure the findings are translatable to the community. Then we begin scaling and development. Here is a quick snapshot of our process and the many evidence-based health interventions that we are advancing through the Y's discovery, developmental, and dissemination pathway. I'll share a few examples of these programs at work. We are most known for our work in diabetes, which happens to be the leading driver of costs in our healthcare system. There are 30 million people living with diabetes, but just under the water's edge, there are 84 million people with prediabetes, and 1 in 2 older adults on Medicare has prediabetes. So the Y looked to the largest randomized controlled trial on lifestyle health to attempt to replicate and scale it. The biggest ever federal investment in lifestyle health was focused on diabetes prevention. NIH and CDC set out to compare the effectiveness of a lifestyle health intervention to the drug metformin for the prevention of diabetes for those living with prediabetes. The trial was called off early when it was learned that the lifestyle arm could reduce by double the incidence of diabetes with people living with prediabetes. For adults under 60, the lifestyle intervention could reduce the incidence of diabetes by 58%, and among those over 60, it could reduce the incidence by 71% if people just lost 5 to 7% of their body weight. But did that program go to scale for people with prediabetes? No. Why? It was too expensive and there was no system in place to deliver the program. Universities involved in this trial came to the Y about 10 years later and asked us if we could deliver the program in the community more affordably and try to take to scale what was literally the most effective lifestyle intervention to date in the country. So, after the Y was able to replicate the original trial in 2 sites for a fraction of the cost, insurers were ready to start paying for the program. The challenge? We had 2 sites, one in Indy and one in Louisville. So we set out to scale the program nationwide with Fidelity. We wanted an entity to officially recognize community diabetes prevention programs, not just at the Y, but for achieving their desired weight loss goals. So we wrote and passed legislation establishing the National Diabetes Prevention Program at CDC. We believe that with federal recognition from the CDC, community-based diabetes prevention programs would be better positioned for federal or private sector reimbursement. Today, the Y is offering the YMCA's diabetes prevention program in more than 1,100 sites in 40 states, and we have served over 63,000 participants. Many other community-based organizations have joined in this effort to offer the program throughout the country. In 2012, the Y was one of the recipients for the Centers for Medicare and Medicaid Innovations grant to test if we could deliver the program with older adults, improve their health, and save the system money. In the 3-year pilot, we exceeded our goal, served more than 7,500 seniors, hit the weight loss goals, and surpassed attendance goals. And the CMS actuaries show that we saved $2,650 per senior over 15 months. In 2016, Secretary Burwell announced the expansion of the diabetes prevention program in Medicare. This was the first ever community-based lifestyle health intervention covered by Medicare. During our work with CMS, we had a separate pilot underway with the AMA, where their physicians helped in the education, diagnosis, and referral process for the DPP. The AMA took the learnings from that process and created an online site and toolkit with the CDC to help healthcare practices participate in the DPP. The site and toolkit called STAT, Screen, Test, and Act Today, is available online by the AMA. They have been a critical partner to many of us in this work. In addition to states beginning to cover the program through their Medicaid waivers or state plan amendments, some insurers like the Blue Cross Blue Shield of North Carolina are stepping up with large investments to ensure all their residents have access to the program, regardless of their insurer. I'm going to switch to another important evidence-based program offered by the Y, a physical activity program for cancer survivors, LiveStrong at the YMCA. Yale and Dana-Farber Cancer Center have shown in clinical trials that this program reduces fatigue, improves cardiovascular function, and improves overall quality of life. It's offered in 42 states in 768 communities at no cost to participants. Since its inception, the LiveStrong at the YMCA program has served over 66,000 cancer survivors. CDC has supported the Y to scale the Enhanced Fitness program to help those living with arthritis and mobility impairments. In a few short years, we have Ys delivering the program in 45 states in more than 450 sites. We have had almost 30,000 participants in the program. The program has been shown to save almost $1,000 a year in healthcare costs, has a 90% retention rate, and shows improvements in falls, depression, and physical and social functioning. Unlike our other group-based programs, the blood pressure self-monitoring program is a one-on-one program with a heart health ambassador that helps individuals use their blood pressure cuffs, better track and record their readings, and have check-ins and attend nutrition classes. This program has been a partnership with the CDC and the American Heart Association. Both have financially supported us in the scaling of the program and providing critical scientific direction. To date, more than 100 Ys offer the program in 30 states and have seen significant reductions in both systolic and diastolic blood pressure. Of the 52% of participants who started the program, about half have become controlled through the program. So started uncontrolled and became controlled. The Y spent many years looking for the best childhood obesity intervention. We recruited an expert panel to assess various programs that were available. We collected and determined that the program with the best outcomes in clinical trials and that fit the Y model was the MEND program. The program was also tested as part of CDC's Childhood Obesity Research and Demonstration Project, or CORD. We have since renamed the program Healthy Weight in Your Child, a program for both child and caregiver. This is our newest program to roll out. While we only have served 1,666 children, we have scaled the program to Ys in 32 states. 81% of children reduce their BMI or slow their weight gain. Importantly, 62% were referred to the program by a healthcare professional. Our key tactical partner in this work continues to be the American Academy of Pediatrics. Outside our healthy living work, the Y works on many upstream factors impacting the health outcomes through our youth development, social responsibility programming. We are one of the nation's largest after-school and early childhood education program provider. We are the largest provider of youth sports and swim instruction. We are the largest provider of camping programs. And we are one of the largest providers of summer, supper, and after-school meals for children in partnership with USDA and Walmart. Ys work to close academic achievement gaps, work to support foster families, and help opportunity youth escape homelessness and violence. And we drive much of our work to help those who need us the very most. Let me discuss some of our health equity initiatives. One of the strategies the Y has been advancing to address health equity is our Safety Around Water program, which is trying to curb the epidemic of drownings in this country, now the leading cause of accidental deaths among children 0 to 4, and the second leading cause of all deaths for kids under 14, second only to congenital anomalies. The crisis hits African American and Hispanic Latina children the most, not surprising when you consider that 60% of African American children and 48% of Hispanic children cannot swim. Partnering with the American Red Cross, the American Academy of Pediatrics, and a host of other national partners, we secured first ever funding for CDC to start a national drowning prevention program this year in the House, and we're working hard to secure funding in the Senate. Ys are also working with other youth-serving organizations to address hunger among our children. Today, we are one of the largest providers of summer, supper, and after-school and year-round feeding programs. The Y served 22 million meals at 5,000 sites to more than 500,000 kids last year alone. And in a congregate meal setting, we work to close the achievement gap. We work on physical inactivity, and we work on food insecurity. With food insecurity, education, and health behaviors as key social determinants of health, this work helps us to address all three factors. And the Y is partnering with the CDC's REACH program on innovative work to try to better identify, refer, and retain high-risk populations to our evidence-based health interventions. We are testing the deployment of a health detailing model in partnership with Health Begins. This model is not unlike what pharmaceutical companies use to sell drugs to doctors, but our detailers will be selling health and prevention, aiming to boost referrals for proven programs in the community and that address social determinants of health. I want to share one more component of our community integrated health work. How are Ys sharing spaces for impact? Ys are building shared spaces with healthcare systems and building teams that can identify clinical needs and social determinants of health. A great example is in Linwood in Kansas City, where a new facility was built with a Truman Medical Center and the Y. Providers can easily refer patients to the Y to help prevent and control chronic conditions. It can serve as a national model on clinic-to-community integration. Another more comprehensive vision that just opened this week in West Louisville, serving a population of 6,000 and a challenged community which has seen no major investment in 50 years. This project took 10 years to organize and is on the site of a former tobacco production company. Market research told the community leaders that 60% of folks in the community wanted the Y and a medical facility. Currently, 44% of residents use the ER for their primary health care. The top facility requests were cardiovascular, massage, and a pool. A focus on the neighbors, crime reduction, and giving children and teens a safe place to go was critical. It's estimated that 25,000 will be served annually through this comprehensive physical therapy services, medical and pediatric care, banking and financial literacy, teen education and workforce development, behavioral and mental health, and via the Ys, health and well-being programs, achievement gap, and out-of-school time and volunteerism. It will be multicultural and intergenerational. Their model recognizes that a healthy community is an educated community and that belonging is a basic need for all. This is a comprehensive vision of community health integration. Not all communities can or will have this kind of sophisticated model. We are seeing more and more models like this, but we are seeing the same models without walls and everything in between. This Y was one of our healthier community sites 15 years ago, building multi-sector stakeholder teams to build healthier community environments, fresh, affordable, available food, places and spaces for physical activity. They've advanced most of our evidence-based health interventions, and they are a diversity and inclusion global Y. They have advanced work to close the achievement gap and more. Many, but not all of our Ys have advanced some of these initiatives and have built skills of looking outward, building bridges, driving with evidence, promoting diversity and inclusion, and understanding that good health outcomes rely on many sectors and the community to realize. Our conference this past December brought 50 national organizations to explore the next frontier of work across the social determinants of health. In closing, it will take strategies that address all these factors influencing health outcomes to have the necessary impact on the critical social issues impacting our communities. Community integrated health is our body of work that will help us better integrate community with a formal health system, from creating healthier community environments to ensuring that everyone has the opportunity to live their healthiest life by advancing health equity strategies, to building the capacity of our Ys to deliver evidence-based programs with fidelity, and to sharing spaces with our healthcare partners for cardiac rehab, physical therapy, cancer care, or having primary care providers inside of our Ys, or jointly building health and human services facilities and Ys together. I hope I've been able to communicate the value of community partners like the Y and what we can bring to our nation's health outcomes through better health integration. Thank you.
Okay, I guess that's is that my clue, Ann? Q?
Take it away. Thank you.
Well, thank you, Katie. That was absolutely wonderful, and it really exciting to see the real, I would say, proactive way the Y is getting involved in trying to change health in the country. And so I'd like to pick up from that and talk a little bit about the same topic, but from the healthcare side, from the medical care side. When I woke up this morning, I looked at my Medscape news scan, and the first article that popped up was a essay or an article that said, patients want a lifestyle program, but where are the doctors? And it was referring to the very slow pace in which the diabetes prevention program that you just described and that the Y is deeply involved in is actually getting implemented. You described some impressive numbers there, but in terms of the entire population of diabetics and pre-diabetics, by the way, diabetes prevention lifestyle activities are not just applicable to those who are pre-diabetic. They're also even more applicable to those who are diabetic. So we're talking about, between the combination of those things, about 100 million or more people in the country. And this article this morning in Medscape said, how do we get the medical side involved and more engaged in that process? So I'm going to talk about that. I call this integrative healthcare, and it is a way in which practice and patients can actually make that happen. You've talked about how the community and you working with the communities have gotten involved, and I want to talk about how the healthcare system, the doctors and other providers can get involved. Now, here's this slide you showed a little bit. As you've mentioned, it's been the National Academy of Medicine and other folks have shown that the vast majority, 80% of what produces health in chronic illnesses do not come from healthcare. In fact, it's only 15 to 20% from healthcare. And so there's a large debate within the policy circles about paying for health care. But even if we had platinum level, complete comprehensive health care for everyone, the question is, would it actually produce health? And the answer is it wouldn't produce very much, only about 20%. So we need to get health care into the business of creating health and well-being, not simply paying for what they're doing now. And I'll illustrate that. Let me show you how this happens in practice now and how it can happen in practice also. I'm gonna use a patient example. So a patient came in to see me after he had had a heart attack. Now, I'm using his name. His name wasn't Joe. This is a surrogate name, but he was a 40-year veteran in the Navy, now retired, and he had come in to see me after a heart attack for some of his prevention and primary care. And Joe had platinum level health care. He had access to specialists. He had access to primary care. He had all his drugs paid for. And so he had the best type of medical care there was. Here's his background, so you kind of understand him a little bit. He's 69 when I saw him, got out of the hospital with a MI. His father had had an MI, a heart attack, at 65 and had died at 75. That's when Joe stopped smoking. He was 35 at the time. He developed high blood pressure at 42. He gained weight after he left the Navy and officially met the criteria for obesity, and then from that developed type 2 diabetes, a very typical scenario. He had good medical care and full benefits. Now, the way the medical profession deals with this is through something that many patients don't know, but every healthcare provider knows. It's called the SOAP note. And SOAP stands for subjective, what the patient tells you; objective, what you observe and test in the office; assessment, which is the diagnosis and the code that allows you to get paid for making the assessment; and the plan, which is the treatment, which you hope is evidence-based. Its focus is on asking what is the matter, medically making a diagnosis and a treatment plan. And everybody who walks into a medical office, because our electronic health records are structured this way, our medical education is structured this way, are immediately put into a SOAP box. And you have to put a SOAP note together which deals with the treatment components. Now, here's the kinds of SOAPs, the diagnoses and treatments that Joe had had over the years. High blood pressure, he was on 2 medications for that. Elevated cholesterol, another medication for that. When he developed diabetes, he was put on metformin, one of those drugs tested in the diabetes prevention program, but he had diabetes already. Obesity, he was referred to a dietitian in the clinic. He saw him once. He said, listen, I know more about food than she does, and I'll show you why he said that in a minute. He never went back. Now he was post myocardial infarction. He'd had a heart attack. The hospital had probably saved his life. He'd had a stent put in, which opened up a blockage that might have killed him, and he was put on another drug called a beta blocker. And he was sent to me for follow-up care and to do cardiac rehabilitation, which was largely supervised exercise. Now, Joe hated exercise. He really didn't like it, but Joe loved food. Joe had been the food guy in the Navy. He had started off peeling potatoes on small ships, supplying food to 15 to 20 people. And then he graduated to large aircraft carriers, 5,000 people. Then he became the oversaw food for entire bases, and finally was a consultant to the entire Navy. And during that 40 years, he'd seen the whole food industry go from scratch, peeling potatoes, to what he called industrial food. This was packaged, usually high fat, high salt, high sugar types of foods that could be heated up and easily delivered in volume at lower prices. On the outside of the Navy, this was called fast food, and many of the young Navy ensigns that were coming in were reared on fast food. So when he tried to get back to peeling potatoes and more fresh food in his mess halls, later on, he found that they didn't like it, and they would leave and go down to the local fast food thing, and he would lose money in his mess hall, and that wasn't sustainable. So it made it very difficult once this transition had occurred. And he told me when he first came in, he said, Doc, he said, I ate this way too. And now I realize that this was part of the problem and why I've ended up where I've been. Now, this type of healthcare, this type of thing that Joe has, and remember, he has platinum level healthcare, as was shown previously, only contributes to about 15 to 20%, that little black part of the ring in the top. And we know that behavior and lifestyle and the social and economic impacts in the orange and the red circles after that is where the determinants of health are. And so we somehow needed to figure out, how do we get Joe out of just doing the soap notes up in the top and addressing these lifestyle and behavioral components. If we don't do that, if we just continue to do healthcare as usual, we will end up with what we have. We are first in spending in the world in terms of costs of healthcare, now $3 trillion. We're 37th in health outcomes compared to other countries in the world, so we're actually not doing very well. The inflation rate of the cost of healthcare going up every year. We could be spending as much as 25% of our gross national product. And because of this rising cost, healthcare disparities, the difference between the haves and the have-nots are widening. It's getting worse in this country. This has been documented in many, many studies, but here's a National Academy of Sciences, Institute of Medicine report several years ago, which compared the health outcomes and costs over 30 years of all the rich countries in the world, what are called the OECD countries, of which the United States is one. And the US was getting worse compared to these other countries in almost all of the primary outcomes that they measured, 9 of the 12 that they measured. And here's a list of some of the ones where outcomes are declining or getting worse in. Here's a slide that shows you how the value of the money we are putting into medical care is no longer benefiting us very well. The value is declining. This is a graph that shows life expectancy of countries in the world compared to the per capita expenditure in healthcare dollars. And as you can see from this, the United States is a major outlier, double the expense of almost any other country, and yet our life expectancy is in the neighborhood of Czechoslovakia or Portugal. And after 80 years of steady improvements in life expectancy, over the last 2 to 3 years, our life expectancy has actually dropped for the first time in almost a century in this country. So we're losing value in healthcare. This is a cultural thing. This is a set of expectations that patients have when they come into the office. It is a set of trainings that physicians get that focus primarily on pills and procedures rather than these underlying determinants of health. And it is a payment system and a research system that puts dollars into that rather than into the underlying determinants of health that we just discussed. So we need to change the culture. The question then from the medical side is, how can the medical interaction be changed to align with what we know now is needed in order to create health in the nation? Well, let me show you what I did with Joe, and I think that'll illustrate most clearly how this can be done. And I call this going from the SOAP note to a HOPE note. And HOPE stands for Healing-Oriented Practices and Environments. And what it is it's an encounter with the patient and the provider that, instead of asking what's the matter, asks the question, what matters? What matters to you in health promotion, and exploring the patient's personal determinants of health. There's 4 different dimensions that are assessed: the physical and external environment, behavioral and lifestyle, of which you've just seen great programs from the Y that are available, the social and emotional parts of the person, which is key to the ability to actually change behavior, and then the spiritual and mental component, which is what matters, what is important, why do you even want health, and connecting that motivating factor to the kind of health behaviors that are needed to produce that. Well, when Joe came in to see me, we did an integrative health practice, and I did a HOPE note, asked those questions, and here's what's mattered to Joe. First of all, he had a lot of medications that he was trying to juggle, and he didn't know how many were important, when to take them, how not to take them, the interactions, etc. So he needed medication management, and many patients increasingly do in our drug-infused society. And we have a pharmacist and a pharmacologist on our team that can help do that. So we could sort that out for him. But what really mattered to Joe is that he didn't want to die like his father did at 75. He was 69, and that meant only a few years. He had grandkids, he had a lot of family and friends, and he said, what can I do to prevent further disease? I'm on all these medications, but I've continued to have problems. He knew that fitness and food changes were going to have to be an important part of that prevention. He didn't like fitness, but that's what was being paid for in his cardiac rehab program. He loved food. Remember, he was the food guy. And he knew that his family and his friends had to be on board. His typical routine was to go to the club in the evening, talk with his friends, have a hamburger and fries, a few drinks, and they would each exchange stories about their medical visits. So he had to get his family and friends' behavior on support. He didn't want to lose that. The most important thing, though, that came out in this questionnaire and this question with Joe was that after he had retired from the Navy, he'd sort of lost his purpose. When he was in the Navy, he was doing something important for the country, for his unit, for the community, but now he wasn't exactly sure how he was giving back, and he was a give back kind of guy, so he needed to figure that out. Well, with that information, we could now set up a team for Joe that I call an integrative health team that could actually help him gain and regain his health. It involved a physician, me. I was really just the orchestrator of the team over the top. It involved our pharmacologist to help with the medication management. It involved a nutritionist, but now it wasn't a nutritionist just giving you a diet. It was a nutritionist that was paired with a chef and a health coach in a program that was in the community, very much like some of the Y programs you've just heard about. This one was in the community on the base. 12 weeks in which they went over what was healthy eating. The chef helped you put it together so it was delicious. He loved that part. He'd been a chef. And the health coach helps you embed it into your life. He needed his family and friends on board. Fortunately, his wife could participate in that program, although it was limited to those with heart disease. And he needed his mind on board. He needed to know he could really do this. He needed to be empowered to do that. Well, he started this program. He did it over 12 weeks. At the end of the 12 weeks, he had lost 5 pounds, and he was feeling much, much better. He came in to see me, and he says, why is this only available to heart disease folks? I needed this 30 years ago. And I said, Joe, that's a good idea. Why don't you help do that? He said, I will. So he then became the chef and the coordinator for this program in the community center and opened it up to others. And he ran that program for a year. I saw him about a year later. He had lost over 60 pounds. He was now off all except one of his high blood pressure medications. His weight had reduced, his diabetes had disappeared, he was no longer on metformin, and the numbers when we tested them showed that his risk factors, based on laboratory tests and other things, were now significantly improved. So he had achieved his goal, and most importantly now, he had regained purpose. He was hooked, and now he was going to be not only improving his own health, but helping others to improve in those areas. This type of healthcare is a different type of healthcare. I call it integrative health. It is the merger of conventional medicine, what I was taught in medical school, and what is still largely delivered in the pills and procedure system that we currently have, integrated with evidence-based complementary practices and self-care, all done within the cultural context, the social and emotional determinants in which it could be delivered. This type of healthcare is where we need to go. If we stay up in this top circle, we will continue to get the poorer outcomes and the increasing costs that we are faced with today. And so the healthcare system now needs to be involved and partnered with groups like the Y that can make this happen, that can empower and support self-care, integrate evidence-based complementary and lifestyle components. The evidence shows when this happens, that this improves outcomes and it lowers costs in these areas. Well, I'm asked often, how can we do this in our current healthcare system? And that's a great question. There's great examples. I don't have time to point to all of them today, but the military, the VA, and many civilian groups are starting to do this. We need to embed this regularly in the system. Healthcare providers can do this already, and they can do this tomorrow. And here's what I recommend to most of my providers, and we've put on our website a toolkit for doing this. First, do your standard of care, obviously, but then do an integrative health visit and use something called a personal health inventory and a hope note that asks the questions about the underlying determinants of health. I'll show you what that is in a minute. Add some simple methods that are non-pharmacological, use advanced healing technologies, and then redesign the teams or partner with teams that will facilitate behavior change like health coaching, team care, group visit, shared visit, decision-making, like the ones that are in the Y. Patients have to be involved in this, finding their meaning. They can take the personal health inventory so that they know, how to begin to ask those questions. They can ask for an integrative health visit in these areas, and then they can develop their own health team and plan and get linked up to programs like you've just heard about. Here's a personal health inventory. I give this to my patients when they come in if they have a chronic illness. And it's a 2-pager. It asks them why they want to be healthy, what's important to them in their life. It screens for what their underlying determinants are, what they're doing already, and it helps us get the conversation going. And I can do it in a 20-30 minute like I would do a regular SOAP visit. I will then take them and do a hope note, and here's examples of some of the questions in each of those dimensions that I showed you that help flesh out those underlying personal determinants, and from that we develop a personal health plan in these areas. That questionnaire also asks about social determinants, housing, food, transportation, safety, etc., to make sure those things are addressed if needed in the community. I have on my website a toolkit that tells healthcare systems and physicians and other providers how to prepare for such a visit, how to do such a visit, and then how to provide the continuing support. And this is where the link in with programs like you just heard from the Y comes in, this ongoing continuing support. And when I saw this huge array of programs that the YMCA is developing here. We're talking about more than just diabetes prevention here. We're talking about chronic disease management. I'll tell you, this list of things covers about 60 to 70% of everybody that walks into my office. And so having a integrated link to those programs after I do that kind of a integrative health visit in the Hope Note is absolutely ideal. Let's get these two groups together to do that. With the scaling approaches within the YMCA, this is something that could be available for any provider, really literally anywhere in the country in those areas. So if you are a provider or a provider network and you want to start embedding this into your own system or your own practice, send me a note. There's my website. We have a whole toolkit on how to do this, and we work with networks around the country in doing that. And I'm going to be talking further with the Y and with Katie after that to see how we can become more integrated with that. So I hope this was helpful for you in seeing the approach from the medical side, and I look forward to the conversation and discussion. Thank you.
Well, thank you so much, Wayne and Katie. Those presentations were excellent, and I think clearly you both are working on the same issue from different vantage points, and I think you've given us a lot of insight as to how the community can partner with health organizations in the case of the Y, and Dr. Jonas, how practices can set themselves up to better meet the needs of patients and link them to community services. So that was really terrific. And a lot of times I think people are beginning to intellectually understand that there needs to be more of this integration and partnership, but how you actually operationalize that is challenging. And my hats off to both of you for the work that you've done. We've got a number of questions about the slides and making sure that they're going to be available, and they will be available for download. We also will put a copy of this webinar so that if there are others that you would want to share it with, it will be on our website within 24 hours, and you can listen to it and see the slides as well. A couple of questions that we've got. One question for Dr. Jonas. What do you see as the major barriers to your notion of integrative care? You know, that diagram that you showed with the three different concentric circles, and in the middle was integrative care. What do you think are the major barriers to realizing that kind of care across the U.S.?
Yeah, I would say there are three things that are sort of inhibiting providers from getting into and doing integrative health. I give talks all around the country and get feedback from them all the time. And the first thing is that they often have not been trained to even know what the evidence is in these areas. So even the diabetes prevention program, with all of its investment and publication, et cetera, very often they don't realize that you can, in fact, prevent and reverse diabetes with lifestyle. And it's scientifically based, these things are. And so, number one, they need to get up to snuff on that. The second challenge, I'm told, is that, well, I don't have time to do this. You know, I'm too busy trying to do all the other things I need to do in healthcare, and I can't ask these additional questions. And my answer to that is you're spending a lot of time with patients with chronic disease and by not asking these questions. And in fact, you do have the time. It's just a matter of reorganizing it. And if they say they don't have the time themselves, part of the problem is that they haven't tapped into the resources like you've seen with the Y, or they haven't organized their own team to be able to appropriately deliver this. So when they have those things reorganized, they can often do that. And the third thing I'm told is that, well, I can't get paid for it. And indeed, it is a little awkward or difficult sometimes to get paid for these things, but there are CPT codes available for the diabetes prevention program. There are many other CPT codes that can get paid for many of the lifestyle and clinical conditions for which lifestyle is available. And on my website, I actually have a guide to providers to show them how to do the coding so they can get paid and even make money in these areas. So those are the three things that often come up as the main challenges that need to be addressed.
Thanks so much, Wayne. I think a lot of times we sort of can throw up our hands and say, well, if only we completely changed the way we were paid, then we could resolve all these programs. And I think what you've just laid out are some things we can do right now to address these barriers. Well, the PCPCC and other organizations are going to continue to work on changing the way payment works and also getting more resources into primary care. This is a question for Katie, and the question is, what challenges did the Y have in implementing your evidence-based interventions, and how did you, connect to primary care or integrated care?
So the challenges continue. We have basically done what we can to train to curriculums that are based on randomized controlled trials. We're training typically lay health providers. There can be transition in staff when you're dealing more with lay health coaches than maybe higher paid practitioners. We have had to help our staff become HIPAA compliant, which is another heavy lift for an organization that book of business isn't really healthcare, but health. We have partnered with, we think, some of the greatest folks in the healthcare field, from the AMA to the American Academy of Pediatrics to our patient advocate groups to basically, and the CDC, to give us street cred, because a lot of people, like I said in the beginning of the call, think of us more like a gym and a swim and don't understand that we spent this intentional effort working with the Institute of Healthcare Improvement Breakthrough Series strategies and, really trying to train our staff to do things innovatively and track quality and improvement. And it's just very hard to bring this level of quality into our space for folks that are really, we want to get this job done kind of people. And yet we've done it. It continues to be a problem to work with a healthcare system with so many different contracts. They take a very long time to secure for our Ys. The data systems are a real nightmare because they don't talk to each other. We have to work to get some parts of the electronic medical record. And again, we're HIPAA compliant in the Ys that are doing most of these programs, especially if they're dealing directly with reimbursement. So from the data systems to the staff training to getting folks to really recognize the quality and the practice we put into this, it'll be an ongoing struggle, but I think you're giving us the opportunity to present on calls like this, to have folks like Dr. Jonas understand the value of this, and to see foundations and federal systems starting to move towards social determinants, which include health behaviors. I think it's the right time, also with value-based care, to be looking towards these kind of community-based solutions that can save us money and really produce health outcomes and not just treat conditions. So that's a lot, but there are a lot of things in this space that are hard to accomplish, but we've learned a lot and are happy to share with others ways that we've tackled problems.
Thanks so much, Katie. Great. I think this really is a question for both of you, given your different vantage points. How do we need to train people differently, both on the provider side and also in the community? And train, I'm using that in air quotes. I mean, how do people need to be coached to perform their jobs differently, to really, consider how we might be more integrative, work across the silos? Obviously, that can happen when they're, early on, getting their training in a professional setting, but also once they're in practice, or for those in the community-based organizations, how do they learn to operate differently? So maybe Dr. Jonas, you can answer that first, and then we'll switch it back to Katie.
Yes, no, happy to be talking about an extremely important question. How do we educate our current and up and coming health providers, and I'll answer it from that perspective, to be able to do this type of thing. Well, one thing is to embed it in medical, nursing, and other provider education. And the Samueli Foundation that I work for has given a very large grant to the University of California, Irvine, to transform all 4 of their schools, medical, nursing, public health, and pharmacology, into an integrative curriculum that educates health providers on how to do this. So that type of thing needs to happen more. We've recently worked with the Association of American Medical Colleges to look at using integrative and non-pharmacological approaches to pain and the opioid crisis, because as you know, this requires less drugs and more non-pharmacological approaches. The evidence is there, the guidelines say we should do it, and so the AAMC and we have partnered at the Samueli Foundation to try to develop curricula that can be embedded into medical education in those areas. And then I work with medical schools around the country to actually teach them how to do an integrative health visit, how to do a Hope Note, how to use these tools I've just talked about. And we've got a number of them around the country that are picking this up and beginning to put them in to their programs early on so that their providers can begin to use them immediately.
Great. Glad to hear that there's so much work going on. Go ahead, Katie.
Yeah, so I'd probably add a few things. One, that we have done motivational interviewing and listen first trainings with our staff so that we stop thinking that we have the solution for them, whether it's a physical activity approach or a nutrition approach, and we actually ask them what their wants, needs, and interests are, not unlike the HOPE tools that Dr. Jonas is using. And that was a big transformation. And we also hire different staff. We really do see the whole idea of facilitating conversation and getting to where people really want to go with their life is more important than necessarily the training they have on equipment and things of that nature. You know, I'll give you a great example of what we need to do too when we think about who we're working with and the populations that need us most. We did a special study with CDC around why so many certain populations, specifically African Americans, were drowning. And when we spoke to families that didn't come to the Y and why they weren't learning how to swim, they said, well, we really need to see more people that look like us and that are just as afraid as we were to learn how to swim. In our community, people don't learn to swim. And so we went out and spent a whole lot of time recruiting African American and Latino lifeguard coaches. There's already a shortage in the industry of lifeguards. And we also created a pathway to career for them. So once they learned how to swim, we were going to make them lifeguards, and then we were going to make them aquatics instructors. And we still have that in our system now. And now you see a real diverse network of folks teaching the very kids that are afraid how they got over their fear. And a lot of that is a cultural sensitivity to folks that need us most.
Wow. Both of you, hats off. A terrific presentation. Really, really appreciate your time today. Thank you all for joining. Our next webinar will be on September 19th at 1:30 p.m. Eastern Time, primary care measurement, what's working and what's not. So I hope you join us. Please join me in thanking both of our speakers today. Thank you. Bye-bye.